Yeah, so good afternoon from my side. Today is infection day, and the first is on analysis of periprosthetic joint infection, and the second one later on is on treatment. So analysis, I have the following content. So the first two slides will be more general slides, and after that we will talk a bit on definitions of periprosthetic joint infections. Then we have a large part of diagnostics. Is not one single diagnostic tool. I think it's a potpourri of a lot of different things you have to combine. Then we'll talk a bit on new technologies and tests that are already available or will be available in the near future. And then I think something very important which everybody should develop for his own hospital is an algorithm. Of course, you can get some guidance from the literature, but it should be always adapted to your local situation, and then of course a short summary. So in general, something that hasn't changed over the time, unfortunately, infection is still the most common cause for early failures, independent whether we talk on knees or on hips. It is the most common cause for early failures. And down here you see the papers from Peter Sharkey, where he combined his series from 2002 and 2012. And you see there are some reasons that came down a lot, maybe due to training, like instability or arthrofibrosis or polyethylene wear. But some other topics increased, and especially infection. It was quite a high bar in the 2002 analysis. 10 years later, it is definitely the bar with the highest percentage in the early revision of up to 40%. So that leads to the general recommendation that we always have to think of infection, and we have to rule out infection. Every joint that is coming to your office not working well, infection should be ruled out. A bit on prevalence, first the general numbers. These are US numbers. You see here, that is the numbers of treatments total hip. That one increased from around 100,000 in the 90s, almost 20 years later to double the numbers to 200,000. The knee at that time started also at 100,000 and now is up to more than 500,000 in 2007, and the numbers over the last years further increased. The very a bit frustrating number is shown here on the right side in that graph. So very simultaneously, even in a higher percentage, we have an increase in the infected total hip arthroplasty. So increasing from 1,000 to around 3,000. And from 1,000 in the total knees to more than 6,000. So that means that we don't have an increase only because of an increasing market, also because infection is percentage-wise increasing. So first of all, I think we should talk a bit on definitions. There are some definitions on the in the literature. So different classifications. Very important is, I think, the time aspect. Every acute early infection is defined as an infection that comes within the first 6 weeks after the implantation of the implant. They have acute symptoms, normally including fever, red skin around the hip or a knee, and a very high CRP in the blood measurement. The acute late infectious is, from symptoms-wise, very similar, but it is defined as an acute infection that is later than 3 months after the index surgery. So that can also occur after 5 years or 10 years. So that is also an acute infection. Opposite to those two acute infections, we have chronic infection. And this is the reason number one, chronic infection starting after the 6 weeks period. They only have minor lab alterations and also minor symptoms from the patient side. One of the symptoms is in chronic persisting pain. So these are the infections harder to diagnose than, of course, the acute infections. This is the classification from the American Association. So it's quite similar. I think they have added the type 1, which is maybe not mentioned in the old classification there. So type 1 is a positive intra-op culture after a revision procedure. So those are misdiagnosed infected cases, chronic infected cases that became obvious during the revision procedure. And the rest is very much the same. Like you see above, type 2 is an acute early infection, type 3 is the acute late or hematogenous infection, and type 4 the chronic infection. The time frames are a bit different, and so in the older one it was 6 weeks, now it's shorter than a month, and the more recent publications on classifications have shortened that period to 2 or 3 weeks. Another, I think, very important paper is that one where the consensus of the Musculoskeletal Infection Society was published. They defined an infection with the finding number 1, if there is a sinus tract communicating with the prosthesis, or it is an infection if there is a pathogen isolated by a culture from 2 different tissue or fluid samples obtained from the affected joints. So if you have one of those, it is always an infection. The number 3, then it is an infection if you have 4 of the following 6 criteria. Elevated ESR larger than 30, and increased or elevated CRP larger than 1.0 concentration. And second, an elevated synovial white blood cell count. Third is an elevated synovial polymorphonuclear percentage. Fourth, presence of purulence in the affected joint. Fifth, isolation of a microorganism in one culture of periprosthetic tissue or fluid. Or 6, greater than 5 neutrophils per high power field in 5 higher power fields observed for histologic analysis of periprosthetic tissue at specific magnification. So that you have to have 4 out of the 6, and then it's automatically defined as an infection. So also very important, I think, to remember, if you see a sinus, it is infection. What are the enemies we have to fight against? I think that is very variable. Depends on where you live, and even in the same city, you can have different germs in different hospitals. So it is very helpful if you analyze on a regular basis your statistics regarding the different germs. So in our area, still the Staphylococcus aureus is the bacteria number 1, more than 1/3. MRSA increased over the time. As you see here in the late 90s, it was almost zero. And then it increased up to 2010 to 19%. If we now look at the